How's it going, guys? So when you first see this immuno question and you see these answer choices, it can appear very difficult. I promise you, this is very simple, and I will keep this very fucking simple. Tell you exactly what you need to know, okay, to increase your score. This is a factoidy type of question, all right? Not waste your fucking time. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. And I also recently created a join button here on the YouTube. You can become a membership. The fuck am I saying? You can become a member of my channel by hitting the join button down below, in addition to subscribing. So now how about I start the actual clip? How does that sound? So we have this eight-year-old boy. He's got a 2-hour history of increasingly severe nausea and confusion. He's obviously febrile 1035, and he has low blood pressure, 85/50, okay? We could articulate the notion that, of course, in pediatrics, we could have lower blood pressure, but this is actually shock, okay? This is clearly septic shock, 24,000 leukocytes. Normal range is 4 to 11. So we keep reading. He's got a rash on his legs and feet that does not demonstrate reduced coloration when pressure is applied. This was me going out of my way to not use the word blanching, okay? So this is a non-blanching rash. Blanching is very buzzwordy. Blanching means that when you press on the rash, you can actually cause the redness to go away. But a non-blanching rash means you press on it, the redness does not go away. This is classic for meningococcus, okay? Why you get a non-blanching rash? No fucking idea, okay? You just do. So non-blanching rash is meningococcus, Neisseria meningitidis. Cervical lymphadenopathy is present. This is actually an important detail because it means we do not have Bruton, A-gamma globulinemia, okay? You would not have lymphadenopathy in Bruton. You get scanty lymph nodes and tonsils. As I said, I was going to keep this clip concise. So the patient has an older brother who's had a similar condition at the age of 10, deficiency of which the following is the most likely explanation for these findings. So cutting to the chase here, you need to know for USMLE that if you get a question where they mention recurrent meningococcal or gonococcal infections, either in a patient or within a family, okay? So in this case, meningococcus in this patient as well as in his brother. As I said, it can be gonococcus as well. This is due to terminal complement deficiency, okay? C5 through C9, you cannot form the Mac-Attack complex, which is necessary to kill Neisseria species, okay? So what the USMLE might do is just simply list C8 as the answer, or C7. Seems very obscure. They could write terminal complement deficiency, or they can write just complement deficiency. Very simple, okay? Not crazy, not a big deal, as I said. So when you take 2 steps back and chill the fuck out, and you say, OMG, immuno, I don't know what's going on, I just say relax. If you have Neisseria infections, you want to think terminal complement deficiency, and you're going to choose C8 complement protein deficiency in this case. Now I'm going to quickly just hop through the other answer choices. Adenosine deaminase deficiency will cause autosomal recessive SCID, okay, severe combined immunodeficiency syndrome. IL-2 receptor common gamma chain mutation will cause X-linked recessive SCID, okay? You're going to have a B and T cell deficiency. You'll have scanty lymph nodes and tonsils. That's your deficient B cells. You'll have absent thymic shadow. That's your T cell deficiency. Deficiency of CD18 LFA1 integrin is leukocyte adhesion deficiency. Classically, staph infections. You can get so skin infections that lack pus, and they can it's very buzzy. They can say delayed separation of the umbilical cord at birth, okay? If they don't tell you delayed separation of the umbilical cord because you rely on that detail as a buzzy crutch, I just want you to know that you will not get pus at the site of infections, because if the neutrophils can't leave the vessel, if they can't diapedese, then you can't form pus, okay? CD40 ligand, deficiency of this will cause hyper IgM syndrome. So what the USMLE will do is they'll just give you a vignette of some random immunodeficiency finding. They'll show you the immunoglobulins that are all low, and then holy shit, IgM is super fucking high. And you'll obviously say to yourself, okay, this is clearly a hyper IgM syndrome. But then the answer will just be deficiency of CD40 ligand. Okay, you need CD40L on the T cell, the Th2 CD4 plus T cell, to bind a CD40 receptor on the B cell to induce isotype class switching. Okay, so IgM is the first immunoglobulin type we have, and it will convert to the other types like IgG, IgA, etc. Look, as I said, I'm not going to waste our fucking time with this question. This isn't meant to be a 17-minute clip where we're dancing around different superfluous descriptors here, okay? So recurrent NASE serial infections, you need to know it's terminal complement deficiency. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.